It happened to me.
People talk to other people who say, gee, I took this medicine and I just feel so tremendously better, and you should try it, because and they see that there's a radical change in this person, and it certainly is seductive.
Yes.
Exactly. It's a seductive thought, and certainly antidepressants absolutely save lives, and there's been controversy that antidepressants can lead to suicidal thinking, and so for a period of time, psychiatrists who are ever afraid of lawyers, since lawyers see us as lottery tickets, that they stopped prescribing antidepressants for a while, and as they stopped prescribing antidepressants, the suicide rates for young people in this country significantly increased.
Wasn't Prozac one of those?
Prozac was one that had a reputation, and what
for rage, I think, was one
for
of the
rage
things,
and suicidality. And what it turns out is that when the data was reevaluated, these medications can cause people, maybe cause or allow people to think more about suicidality, but they act on it less. And it's important to remember that that these medicines can absolutely save lives. And there absolutely is a place for them. The primary prescribers of antidepressants in this country aren't psychiatrists or primary care doctors.
Exactly.
In fact, they prescribe all kinds of things in psychiatry, even for some fairly sophisticated and difficult situations, such as people that are truly bipolar, not sort of a popular notion of what bipolar is, which is just general moodiness.
Right.
But the true diagnosis of bipolar disorder, which can really destroy people's lives. And there's primary care doctors that are prescribing that. And once again, that has more to do with, I think, the pharmaceutical industry, which has these really great atypical antipsychotics. And they've been pummeling doctors with these agents, saying, this agent works really well for bipolar mania, and you're probably missing the diagnosis. So you really need to pay attention to this. And I've even seen in my office, in some women's magazines that we get, that there's a questionnaire for women to answer if they have bipolar or not. But the questions are, have you ever been moody? Have you ever gone on a shopping spree? Do you feel negatively about your weight? I mean, just generic, foolish things for which they can all say, I have bipolar. In Rhode Island, once you get that diagnosis, what I've seen, the next stop is disability determination services, because you can get on disability and slide into that sweet parking spot over at the Walmart. And it's ridiculous that it's being diagnosed so quickly and easily. And once again, it goes back to, I think it ultimately goes back to medicine's fear of lawyers. Am I going to miss a diagnosis? Are people going to sue me? And am I going to lose my shirt?
How long does it take you to make a diagnostic determination for someone that you've been working with? How many sessions do you work with somebody prior to, or do you use third-party information that you get as the person's coming in, that they've got a long history with some other physician and they're now being referred to you because they think that there's this co-occurring issue or something of that nature? Do you let it sit for a while before you make your determination, or do you jump right in there?
Well, that's a good question. It depends on the circumstances. Regarding the getting a referral from another physician or from a hospital, I've made it a practice not to look at the referral until after I've seen the patient, because I'm always afraid it's going to have an impact on my judgment. And then I'll do the evaluation and see if the hospital or the physician and I agree on the diagnosis. But it depends, once again, on the diagnosis, because there are some people I've treated for a number of years, and this is embarrassing to say, that where I've missed the diagnosis, and there's something else that was actually going on there that I wasn't aware of until a family member or some crisis made me aware of it. Other cases where you're sitting with somebody, and in the first 30 seconds, you get a sense that there's really something significant going on here that's suggestive of fill in the blank. And I think part of it is the beauty of psychiatry, as I see it, is that the longer you're in it, I think the better you get. And certainly I feel more comfortable in my diagnosis now, being out of training almost 20 years, than I was 5 years or 10 years out of it. I always advise people to find a pediatrician with gray hair and a psychiatrist with gray hair, because you want somebody who really has seen it all.
Mm-hmm. Now, you have therapists that work as part of your practice too? Do you refer out? How do you kind of deal with the notion that, for example, I give a person an antidepressant, but that's only part of the answer? They probably need some kind of either cognitive behavioral therapy or something of that nature to add to the therapeutic regime. What do you have people you refer to?
Sure. I have a half dozen therapists that work in my office that I have tremendous respect for, male and female, that are seasoned clinicians, that are very thoughtful and kind, people that I would send a family member to, or
Mm-hmm.
I would go to see if I needed to, and it's a very good point about bringing in the notion of therapy to in conjunction with medication, because these medications, for the most part, it really is like putting a Band-Aid on a gunshot wound for some folks, and it's important that the underlying issues can be addressed, how they're functioning in their family, how they're functioning in society or in their occupation. And it's critical. The other thing is that these antidepressants will work as long as they're taking them. And there was a really eloquent study done a few years ago where they looked at PET scans of people's brains before and after therapy and before and after medication. And these were people that were sort of identically depressed. And what they found was that their brains seemed to change identically. That 6 months of medication would change their brain, and 2 years of psychotherapy would change their brain. But when the medications were withdrawn, a lot of people, unfortunately, will go back to their baseline, whereas with therapies withdrawn, well, people have received these gifts they can carry with them the rest of their life for coping with stress.
That's interesting.
It is.
So the combination obviously is important, but also the chemical rebalancing of the brain is a significant part to
absolutely.
help recovery.
It is, and they found with antidepressants when they first came out that it actually would help people to do more efficient work in psychotherapy, because the pain wasn't quite so raw, and they could move along a little faster, more efficiently.
People with schizophrenia, do you believe that they would benefit also from a therapeutic?
Boy, there's just been some studies in the literature in the last few weeks that corroborates what was said years ago, that these people absolutely benefit from psychotherapy. If any group would, you'd think they would, because they often become really disenfranchised and abandoned by society, and it helps with psychosocial functioning, but it also helps to be seen by somebody else who can kind of monitor their medication intake and how they're doing.
That's important.
Very important.
Clozaril, do you have folks that
Great medicine.
Yeah.
Great medicine. It's the downside of Clozaril is that you have to, at least in the first 6 months, do weekly blood level checks to make sure that their white blood cell count doesn't drop. But beyond that, it really is an amazing medicine for, and that was really the first atypical, an amazing medicine for helping these people who have this nagging treatment-resistant depression.
Well, also the positive symptoms of schizophrenia are dealt with very effectively, often with Clozaril.
That's correct.
We've seen that in our organization.
Yeah.
Which I think is just wonderful for folks that are no longer hearing those same voices that they were hearing before.
Absolutely.
Or they're muffled, or in some cases they're gone.
Yeah, it is. For a lot of people, it's been miraculous.
Yeah, we have a number of people that we work with that were at Eleanor Slater Hospital for years, and until the advent of Clozaril, they probably would have stayed there, but now they're out living in apartments, having a quality of life that you wouldn't imagine they would have been able to do without the medication.
You know, that's a great selling point for Clozaril, and a lot of doctors are hesitant to use it because of the monitoring of the blood level, but and it certainly there is a disadvantage with prescribing it for patients. But boy, when it works, it really works tremendously well.
You're right, it has to be closely monitored. There's also body image issues, too. We've had some people that have said, I can't take this anymore, I've gained too much weight, and I don't like the way I look, and yeah, I'm thinking more clearly, but
at what
I
price?
Can't get a date.
Sure,
you know,
exactly.
That kind of a thing. So.
Right, that's the thing that comes across with a lot of these medicines. You know?
Yeah.
You're trying to improve the quality of their life as they're ballooning.
Well, every one of the psychotropic meds has some kind of side effect.
Correct.
Some kind of negative aspect to it that people either have to tolerate, or they're not going to take it, but then what comes back are some of the positive symptoms of their illness.
Certainly.
So it makes it very difficult. we've only got a little bit of time here. I wanted to ask you about the other notion that happens in psychiatry is cocktails. We had a pharmacist talk about the fact that if a person has bipolar, they take lithium. They don't take risperidol, they don't take benzodiazepines, they don't take anything else. Lithium is indicated for bipolar disorder. Give them lithium, and let's not muddy the water with a lot of other meds. But I know I worked at Boston State Hospital in 1972. And at Boston State Hospital, there was cocktails all the time. Of course, it was only stelazine and Mellaril and Thorazine and Haldol that was being given. But there was other medications that were put on top of them to try and figure out a match for the person, is what's going to help stabilize the person. In terms of your efficacy in ruling in, ruling out meds, do you start with just one, two, like maybe an antipsychotic with an anticholinergic with it, or do you sometimes add some more pieces to it and sort of rule in and rule out as time goes?
Well, of course, it depends on what the diagnosis is. If somebody comes in and they're psychotically depressed, the rules are that you treat the psychosis and the depression at the same time. In a bipolar condition, if somebody comes in and if they're full-blown manic, they need to be hospitalized. But if they're less than or hypomanic, you do want to put a mood stabilizer on board. Lithium's a nice medicine. I think that there's cleaner medicine, since lithium can certainly have an impact on weight gain, fluid retention, kidney function, thyroid function, a lot of things. But when lithium works, it's really great. But that's going to help with the mood disorder, stabilizing the mood rather. But you do want to add. I think that it helps to add just a low dose of an antipsychotic, because it can help to slow down their thoughts more acutely.
In terms of benzodiazepines, addiction psychiatrists are all over the place in terms of, do we prescribe, do we not prescribe? Are we just adding another addictive function to the person's plate of dysfunction? Where are you on the continuum of when would you use Klonopin, for example, or not?
Well, that's a great question, and there is a lot of controversy on it. And I think, once again, it gets down to the individual patient. When I was in training, I thought, I am never going to use benzodiazepines again, because they're nothing but trouble. And they are trouble, since most people develop a tolerance to them, and you got to increase the dose, and you're off and running. But there are patients that have come to me that have been on something for years and years, and it always gets down to quality of life. And if these people aren't abusing it, that's fine. The other situation would be where a family member can monitor the patient taking it. Sometimes it's all that can help them to enjoy life.
Obviously in very slow or very low doses.
Very low doses, and closely
0.25, 0.5,
right, very closely monitored.
Okay. Now another medication